All right, thank you very much. Hard acts to follow there, but very exciting talks. So this project that I'm going to show is just the result of persistent wondering about a kind of weird question. Why on earth do left isomerism heterotaxy patients get the worst pulmonary AVMs in the Glenn stage? Now there's a lot of specific words there, so let me back up a minute and lay a little groundwork. So in patients with normal anatomy, we see venous flow from the liver arriving fairly quickly and directly to the lungs, and they have pretty normal lungs. In patients with the Glenn anatomy, we see that hepatic venous flow pumped out instead to the body, where it passes through the systemic capillary beds, the head, neck, and arms, before it has a chance to get back to the lungs. So in the absence of what I call direct hepatopulmonary blood flow, we see pulmonary AVMs. There's no genetic mutation, there's no trauma, there's just redirection of blood flow and loss of direct access of this hepatic factor, whatever it is. And the initial observations of this phenomenon were actually made in the 70s, but it was Deepak Srivastava's 1995 paper in Circulation that kind of brought it mainstream. But this was a heterotaxy paper. I mean, look at these descriptors of the patients he described when he's like putting forth this hepatic factor hypothesis. Heterotaxy with polysplenia, heterotaxy with asplenia, biliary atresia with congenital heart disease. Like, this is a heterotaxy paper. So, among heterotaxy patients, multiple case series have shown, and pretty much any pediatric cardiologist will tell you that left isomerism patients get hit the hardest with the pulmonary AVMs in the Glenn stage. So this is confusing to me. And in the spirit of trust but verify, I set out to quantify the AVM severity in our local cohort and found that, sure enough, left isomerism was a clear risk factor for the severity of pulmonary AVMs. And what I'm showing here is this score I kind of made up, but was also taught. The time it takes for contrast to travel through the capillaries in the lungs. And on the top you have the normal, which is about 3 cardiac cycles, and on the bottom, anything less than 2 tends to be severe, and all the left isomerism patients fall into that category. So let's come up with some hypotheses. Why is this happening? First off, well, they're losing this hepatic factor, whatever that is. I find that unsatisfying. It's not the whole story, because that applies to all Glens, not just our left isomerism Kawashima patients. Is it due, perhaps, to some inherent defect in primary cilia? And we have left versus right isomerism. Maybe there's something innately different in those ciliary function, and that might be driving the vascular differences here. Unfortunately, as I'll show, the endothelial cells do not usually have primary cilia. So that was maybe not the best explanation. Is it actually just altered hemodynamics? And we know that these patients are getting blood flow both from the lower extremities and the upper extremities, as opposed to all their other compatriots in the Glenn stage. And maybe is there something to do with the turbulence, the actual like loss of laminar blood flow that we see here in these kids? And that's what I want to start with. So this question, does the Kawashima circulation have flow reversal? Well, you already saw some of that in the first presentation, and I'll have an angiogram shortly that will look very similar. But I want to make this point. We get all our cath and MRI and echo and CT data with a patient lying flat on a table. The only piece of data we get from our patients when they're not lying flat is the exercise stress test. And so kids are not spending their lives on their back, thankfully. We like them to live most of their days upright and running around. And so my guess was that this Kawashima flow in an upright patient is not very steady. And there's no valve in this circuit, and you don't even get some of the boost to pulmonary blood flow like a Fontan would with that kind of downward motion of the diaphragm, squeezing your liver and augmenting hepatic blood flow. So I decided to look at the cardiac MRIs of our Kawashima patients. Again, recumbent, but what can you do? And so I'm not an MRI wizard, but the MRI wizards have figured out how to use MRI to measure flow. And if you're imaging a slice through a vessel, that MRI can tell you which direction the blood is flowing if you acquire the sequence in the right way, and how fast. And it can give you a graph of the average velocity over time, and we use this to great effect in driving clinical decisions now, which is really fun. But that data that they're giving you is like an average of the flow in all the pixels within that vessel. And so I started to look at the area. You can do 4D flow, and there's some really cool paper that Harvard's done recently that have done this in these patients. But I didn't have access to those sequences, so I just decided to look at the area of the vessel where the blood flow is going backwards versus going forwards as kind of a surrogate of blood flow turbulence and reversal, averaged over time. And that's kind of representing some of that backward flow that you would see in a turbulent flow. And when you average that out, and this is just a small cohort of 5 patients who are Glenn, 5 patients who are Kawashima, but the pattern is starting to develop here, and there's definitely more area of backward flow in the pulmonary arteries of these Kawashima patients compared to the Glenn. All right, so here is an example of what you saw in the first presentation, which is really cool. And this is an example of how bad it can get. This is the Kawashima patient who has complete flow reversal in the azygos, secondary to a portosystemic shunt. And this patient's resting oxygen saturation was 70, and their transit time on the pulmonary angiogram was 1.3, which is consistent with severe pulmonary AVMs. So I wanted to think about what effect does turbulent blood flow have on endothelial cells? How are they sensing it? How are they reacting to it? Is this maybe that element that makes them have the more severe pulmonary AVMs? So I got excited when I saw this video. Maybe endothelial cells can sense and react to turbulent or oscillatory flow because they have primary cilia, and the primary cilia are out there getting deflected with all these funky flow patterns, and that leads to downstream signaling and intracellular calcium transients and things like that. What you saw here in this video is actually not a blood vessel, it's a renal tubule. And that deflections that you're seeing there are caused by, you get a pulse of blood, you get a pulse of glomerular filtrate, and actually you end up with flow that's sensed by the renal tubules. Actually some cool research at Mount Sinai on this kind of thing. So then I went looking in mice to see whether the endothelial cells of the pulmonary arteries had primary cilia extending into the lumen of the blood vessels, and unfortunately they just don't. When I started by looking at the distal air spaces out in the alveoli, and I couldn't find a single endothelial cell with a primary cilium. And again, I had a motivation to find it and couldn't. And I looked at multiple developmental stages, both prenatally and postnatally, and they're just not there. And when you look a little more proximally in the main pulmonary artery, kind of as it's branching into the branches, you will see some. They're very rare. It's about 1 in 1,000, but they are there. And when you think about those regions, they're kind of around the curve. And so you also see it in the aorta, but in the lesser curvature, not in the greater curvature. But we can talk about that after. And what it boils down to is that, at least in vitro, I can reproduce this by putting the cultured pulmonary artery endothelial cells under oscillatory flow. So if you take the cells, they're on a little plate in a channel, and they're under continuous flow, and they align to that flow, and they react to it, but they don't have a primary cilium. Under oscillatory flow for 24 hours at the same level of shear stress, they do start to express primary cilium, which is very interesting and kind of gave me another tie backward into the whole left versus right isomerism thing. So I can't get biopsies of the Kawashima circuit, and I wouldn't want to. But so I tried to think of some other biological correlation where it's like, where's an example where we have flow reversal? And I thought about the ductus arteriosus, compared from the prenatal stage where you have flow going across it from right to left, and then postnatal, your pressures change, and then you're flowing now from left to right. And I wanted to see, well, maybe we see induction of primary cilia in this stage. And this is a dissection from a mouse, not a frog. So let's start with our control here. This is the descending aorta, and we don't nice laminar flow in the descending aorta, and you don't see any endothelial cells with primary cilia here. Similarly, in the ductus arteriosus, which is kind of the blank space going sideways across your screen, you will see some cilia out there, the little pink dots. But if you scroll through in the Z-plane carefully, they don't actually come out of the endothelial cells into the surface of the vessel. So again, no primary cilia at this point. Now, try to speed up here a little bit. So this is right after birth, P1, day 1 of life, in the ductus arteriosus, and we start to see really nice, clear primary cilia coming off of these endothelial cells after this flow has reversed. And then this is kind of a little bit further out into the ductus with, you get these globular, gross-looking endothelial cells. They're not nice and linear and flat anymore. And then by day 4 of life, let's see if I can play this. There we go. You can see you're down to the few last remaining endothelial cells, and some of them still have the primary cilia, which is there, and that orange staining in the middle. Sorry for the blob on the side. Yeah, so I thought that was really fun. Now, so the conclusion here of this kind of very limited study is that endothelial cells express primary cilia, but only during flow reversal, and potentially in response to this turbulence in Kawashima. So I have a lot to learn here, but this is one of my current avenues of investigation in trying to understand the severity of pulmonary AVMs in these patients. So we're going to be using some genetic models to knock out cilia in the endothelial cells and look at the ductus and see what we can learn from the ductus and apply backwards into our patients. And that's just quantification of the number of cells that are ciliated. Thank you very much for your attention, and I thank my family and all the people here who have been supportive and mentors in all this work. So thank you very much.